Peritonitis by Amanda Beal. My name is Amanda Beal. I'm from ASU VB on the Searcy campus LPN program, and today I'm going to be teaching you a little bit about peritonitis. Etiology and pathophysiology of peritonitis. It is inflammation of the abdominal peritoneum by fecal matter seeping from a rupture site, causing bacterial contamination of the peritoneal cavity. It could also happen by chemical irritants, which are blood, bile, necrotic tissue, pancreatic enzymes, and foreign objects. Another way to get peritonitis is people who use continuous ambulatory peritoneal dialysis are at a higher risk for infection. They're at a higher risk for infection from bacteria. The people who have ascites, which is swelling from fluid in the abdomen. But either way, it could lead to possible sepsis and massive fluid shifts. Clinical manifestations. Severe abdominal pain. Any movement is painful. The patient usually lies on their back with their knees flexed to relax the abdominal muscles. You'll feel muscular rigidity, rebound tenderness, and spasms are major symptoms of irritation. The abdomen is extremely tender to touch, which is a major sign. I've attached a picture so you guys could see what a normal peritoneal cavity should look like, and then what the inflamed one looks like. Big difference. Now you can see why it's so uncomfortable for one. Assessment. Subjective data. Observing for severe abdominal pain. Nausea and vomiting can occur, and as peristalsis ceases, constipation can occur with no passage of flatus or gas. The patient will also have chills and weakness. Assessment as well with objective data. They'll have a weak and rapid pulse, have a fever, low blood pressure, leukocytosis, and dehydration. They could even get so weak that they can collapse and potentially die. Here I provided another picture of a person with peritonitis. You can tell that they're in distress. They have fever, they're feeling nauseous, anorexia, meaning they're not hungry. They have an increase in their pulse, an increase in their blood pressure, they're dehydrated, clearly they're in pain, decrease in their bowel sounds, rebound tenderness. It's a cute little picture to go back and look at. Diagnostic testing. Abdominal x-rays will be done to look for free air under the diaphragm. They also will do a CBC with differential to determine the degree of leukocytosis. A blood chemistry profile will be completed in order to determine the renal perfusion and electrolyte balance. Peritoneal aspiration will be done to test the blood, bile, pus, bacteria, and fungus. And they may also do an ultrasound and a CT scan to identify any abscesses or ascites. I've attached a picture of peritoneal aspiration and peritoneal dialysis. The medical management could be a pretty aggressive therapy for the correction of contamination and the removal of chemical irritants by surgery, and most often they're going to get perinatal antibiotics. NG intubation is ordered to prevent GI distension. IV fluids and electrolytes are administered to prevent or correct imbalances. They may also provide analgesics for the pain. The patient may be placed on total perinatal nutrition because of the increased nutritional requirements. And early treatment is beneficial to prevent severe shock from the loss of fluid in the peritoneal space. Here I've provided a few pictures to show you the NG tube. To the left is how you measure, and the picture on the right showed you the NG incubation going all the way down into the stomach. Nursing interventions. Place the patient on bed rest in semi-Fowler's position to help localize lower abdominal pain. Don't forget to provide good oral hygiene to prevent drying of the mucous membranes and cracking of the lips from dehydration. Monitor fluid and electrolyte replacement. Encourage turning, coughing, and deep breathing exercises. Some patients may have shallow respirations as a result of abdominal pain or distension. Use measures to reduce their anxiety. And if the patient has a wound, go over surgical asepsis with them. Here I've attached more pictures of peritonitis. The one on the left is showing you the buildup of fluid and the inflammation. The one on the right is a real-life picture of the inner lining walls of the intestines being inflamed, which causes the pain. Patient teaching. You have to explain to the patient the importance of ambulation, turn coughing, and deep breathing. Teach him how to use an incisive spirometer and leg exercises. Stress the importance of asepsis for wound care dressings. They need to have a nutritional diet, and you need to go over not lifting more than 10 pounds with them until the provider approves it, so they don't open any wounds or scars they may have. And it is very, very, very important for them to follow up with their primary care physician. Prognosis. It depends on how fast the infection was found. If they find it early, there's only a 5% of cases where people don't make it. But on the other hand, if they found out late, 30% of the people have problems and end up dying. Delayed treatment often leads to gastrointestinal bleeding, renal dysfunction, and liver failure. I hope you enjoyed the PowerPoint on peritonitis. And if you have any questions, please feel free to shoot me an email and I'll try to get back to you as soon as I can. Thank you.